Welcome back. This is episode 7, the final episode of this Full-Arch FP1 series. If you've been following from the beginning, you know we've covered digital planning, DST, guided bone reduction, implant placement, and today we close the loop. After the bone reduction and implant placement, we're left with this: implants in position, bone leveled, soft tissue open. And now comes the part that most full-arch courses skip entirely, the soft tissue game. Because FP1 is not just about the bone, it's about what sits above that bone. And the tissue that will define whether this case looks like a prosthesis or looks like teeth. In full arch FP1 rehabilitation, the pink-free protocol, the soft tissue, has to do everything with the pink ceramic or acrylic would do in an FP3 case. There's no flange, no artificial gingiva. The mucosa is the gingiva. So if you don't have volume, you get black triangles. And if you don't have keratinized tissue, you get recessions and maintenance problems. And if you don't manage the contour of your provisional correctly, the graft has no space to mature. This is why we perform connective tissue grafting simultaneously at the time of the implant placement or at the second stage even, full arch side by side wherever the tissue envelope needs building. The evidence is clear on this. Thicker peri-implant mucosa correlates with better marginal bone stability and better aesthetic outcomes long term. Now, to allow the graft to heal, mature, and actually grow, you need to give it space. This is where the concept of subcritical contour becomes essential. The emergence profile of any implant restoration has two zones: the critical contour and the subcritical contour. Now, the critical contour is that area that supports the free gingival margin, and the subcritical contour, everything apical to that, in contact with the sulcular epithelium and connective tissue. When you're doing a CTG simultaneously with immediate loading, we deliberately undercontour the subcritical zone of the provisional. We give the graft room, we don't compress it, we let biology do the work. Here you can see clearly the difference between an over-contoured profile, the red line, and the correctly designed subcritical zone, the green line. And you can see that the red profile compresses the graft, compromises vascularity, and risks necrosis or resorption. The green profile creates a protected space for the tissue to integrate and volumize. This is not just aesthetics, it's biology. Now let's talk about the provisional itself. We fabricate the provisional before surgery based on our digital planning, our DSP, or even our wax-up. The critical contour, the emergence at each tooth, the gingival zenith positions, they are already defined in the lab. But the subcritical zone, that's left open, and that's intentional. Because on the day of the surgery, after we place the CTG where needed, after we know exactly how much volume we've added, where the tissue sits, what each side looks like, we do the pickup intraorally. We connect our provisional to the implants with pickup abutments or multi-unit abutments, inject resin into the open subcritical areas, and we customize each site based on what we see clinically. Everything is ready for the pickup, and here's a point I want to make clearly. And I know some of you will push back on this. I still do this conventionally, not digitally, not milled, not printed. And why? Because the aesthetics are unmatched. A conventional pickup done carefully gives you a surface texture, a translucency, an optical quality that no printed provisional matches today. And milled provisionals, apart from the cost, they take time you don't have intraoperatively. This technique, as described by Gallucci, remains 20 years later the gold standard for full-arch immediate loading provisionals. And 2 weeks later, this is what we see. Healthy gingiva, perfectly adapted to the provisional, volume exactly where we planned it. Look at that volume that we've added with the full-arch CTG. Every interproximal space has tissue, every site we grafted has responded. And this is the window that matters. The provisional is now the scaffold for soft tissue maturation. Over the next 3 to 6 months, this tissue will mature, keratinize, and the subcritical zone will be gradually modified, adding contour incrementally until the tissue tells us we're ready for the final impression. And this is where it ends, or rather, where it begins for the patient. From this to this, and look at the gingival architecture, natural papillae, no black triangles, tissue sitting exactly where it should be. From above, a full-arch screw-retained, zirconia-based FP1 restoration, no pink, no flange, just teeth and tissue. And from the side, you can see the lip support, the incisal edge position, the vertical dimension, all restored, all planned from day one. And this is what guided surgery and digital planning deliver when combined with biological understanding. The plan becomes the result. This patient went from a failing dentition, hopeless teeth, altered vertical dimension, compromised aesthetics, to a fully rehabilitated arch, FP1, screw retained, maintainable, beautiful. Look how natural is the definitive prosthesis, shapes and color, white aesthetics scored through the roof. Not less important, the natural look of the soft tissue texture and contour. For me, the pink aesthetic score is 14 out of 14. And this wrapped up our Full-Arch FP1 series, 7 episodes covering everything from initial diagnosis and DSD through guided bone reduction, implant placement, soft tissue management, and final prosthesis delivery. I hope this gave you a complete picture of what it takes to execute a true FP1 case, not just surgically, but biologically and prosthetically. If you want to go deeper, the detailed protocols, the specific CTG techniques, the criteria for subcritical contour modification, a tip-free call visit, and a few Q&A on the questions that this series raised. All of that is on Patreon, link in the description. And if you want to follow the clinical thinking behind these cases, not just the steps, but the why, I write about that on Substack. Newsletter, clinical essays, and philosophy behind the decisions, also in the description. Follow us on Instagram for real-time case updates. If this series was useful, share it with a colleague. This is how we grow this community. And I'll see you on the next series.